But then whose Facebook login to be used?
Some doctors, if we can use Rupin sir's or even Datta sir's or Swarupa ma'am's.
You can use mine, no issues.
Ma'am, एक
Or
काम.
we can do it through YouTube. That will be better, more secured, I guess. Facebook से.
फेसबुक का मैम रीच बहुत अच्छा बढ़ जाता है इमीडिएटली.
YouTube अकाउंट पण लागेल मॅम त्याच्यासाठी. सो
दोनों कर सकते हैं. फेसबुक का इंस्टेंट रीच आ जाता है, बहुत अच्छा आता है.
Okay.
Yeah.
So what do we have to do for that?
Just स्मिता.
मैम सर स्वरूपा मैम को होस्ट बना के once she gets that option she can. मॅम तुम्हाला फक्त लाईव्ह ऑन फेसबुक वर क्लिक करायचंय. ते फेसबुकचं लॉग इन पेज उघडेल, तिथे तुमचं युजर आयडी आणि पासवर्ड टाका आणि मग ते शेअर करा.
I can do it right away, or I should do it in between the session?
No, you can right away. You can do it. That's better.
डॉक्टर साहब, देयर इज अ कंसर्न. डॉक्टर रुपिन ने अभी तक लॉग इन नहीं किया है. 11 बज गए हैं.
फोन करा.
कॉल करू का?
हो, कॉल करा.
Yes,
कॉल
yes.
करा.
कॉल करा.
He's not picking up. I think he should be logging in. Actually, he had logged in. I don't know what happened. Must be some problem.
Nali, moment he logs in, co-host बना देना.
Yes, I'm actually searching for his name.
Pick up नहीं का?
हाँ sir.
He's not picking up the phone.
He is not picking up. He had logged in, sir. परत log out झाले.
Okay.
हाँ sir. Mrinali. Hello.
Yes, madam.
Yes, ma'am.
Yeah, sir is saying the meeting has been logged by host, so he's not been allowed to come in. Just check, na.
Okay, by mistake. Now, ma'am, it is not logged.
Sir, just check now.
काय बोलली तू?
It is still showing logged, Pranali. Just check.
Yes, ma'am, I'm checking. I've unlocked the meeting.
Sir, that technician is unlocked from here. Just check again.
He's come now. He's come.
Okay, sir. Yeah, okay.
Yeah.
Yeah, I think we should start. Patania sir, आप चालू कर दीजिए.
Yes, co-host बना दीजिए सर को. बस we'll start then.
Nali, be a little careful, huh?
Yes, sir.
Yeah, Dr. Swarpa, can I go?
Yeah, please go ahead.
Dr. Rupin is there, no?
Yeah.
He's there.
He's there.
No, start. Okay.
He's made co-host also.
सर आप अनम्यूट कर दीजिए आप.
Unmute कर दीजिए डॉक्टर रुपिन सर.
Yeah.
रुपिन सर आप अनम्यूट कर दीजिए आपको. मैंने कर दिया यहाँ से.
Now it's okay.
Yeah, okay.
Now he's there. Everything
आप
okay?
Yeah, now it is okay. So, Patania sir, you start.
Yes. Good morning, doctors. I welcome you for this Thane Obstetrics and Gynecology Society webinar of the management of OAS and azoospermia. On behalf of Manish Vizera, I welcome you all, and I welcome Dr. Surupa Iyer, the moderator of the program, and I hand over the session to Dr. Surupa Iyer. Welcome, doctor, and over to you.
Thank you, Mr. Patania, and thank you, Swaizera, for their gracious support. I'm Dr. Swarupa Iyer, moderator for today's webinar. I welcome you all to this beautiful Sunday morning. And as per the tradition of Thane OBGY Society, we have been presenting with brilliant academic webinars since the period of lockdown. We have utilized probably the lockdown in one of the best ways possible, and making knowledge reach to all the doctors in the comfort of their own houses. And today we have a topic which is, though nowadays discussed very commonly, there were days when the infertility was attributed only to female factor. But gone are the days, probably credit goes to pioneer people like Dr. Rupin Shah, who has been instrumental in making us all aware about male factors. So I hand over the proceedings to our two stalwarts, chairpersons for the sessions, our president, Dr. Rajiv Laur, and our secretary general, Dr. Panandikar. Both have been very, very dynamic in arranging these webinars, and probably TOGS is the only society who is holding this academic feast every Sunday without fail. Probably we had one holiday of Ganpati and that's all, and we had been having this every Sunday. So over to Dr. Laur.
Hello. Good
Yes,
morning.
sir.
A very good morning to all of you friends, and a warm welcome to all the delegates attending this webinar. Practical Management of Oligoasthenospermia and Azoospermia by Dr. Rupin Shah. The organizing secretary is Dr. Datta Panandikar, and the webinar moderator is Dr. Swarupa Iyer. Friends, oligoasthenospermia is one of the most common anomalies seen in semen parameters. It is treatable, and it is treatable both medically as well as surgically. Now, with the advent of ART, the treatment, medical and surgical treatment, has taken a back seat. So when to offer ART to these patients, when to offer medical therapy, what surgical options we have. And there are dynamic changes in the treatment of azoospermia also. Now an azoospermic male can think of having his offspring with his own sperms. Then we need to have our concept cleared about hormonal assays in azoospermia. And also what are the procedures known as micro-TSA and TEFNA. So to clear all these concepts, we have invited Dr. Rupin Shah. So I will now introduce Dr. Rupin Shah. Dr. Rupin Shah is a urologist who has dedicated himself to andrology. He has dedicated himself to andrology, the super specialty that deals with male infertility and impotence. He is a leading expert on these subjects in India. After completing his MS in general surgery and MCH in urology from Bombay University, he went to Belgium for training in andrological microsurgery in 1986. He was the first urologist from India to have this training and is a leading expert in the area of microsurgical VEA for the treatment of obstructive azoospermia, microsurgical vasectomy, reversal, and microsurgical varicocelectomy. He has conducted numerous training workshops in India and abroad, demonstrating microsurgical treatment for male infertility. He is also associated with several IVF centers and has a vast experience in sperm retrieval procedures, including microdissection TC, and has innovated new approaches. His other area of interest is the treatment of organic erectile dysfunction, a field in which he has made numerous contributions. He has developed India's first penile prosthesis, which is now the most commonly used penile implant in India. In 1994, at the 6th World Meeting of Importance held in Singapore, he was awarded the President's Video Prize for developing a new technique of microsurgical penile revascularization. He has won numerous other awards, including Urological Society of India's President's Gold Medal, and has been honored by President of India with prestigious Dr. B.C. Roy National Award for his contributions to the development of andrology in India. He was the founder president of SASSM, the South Asian Society of Sexual Medicine. Dr. Shah has presented and published extensively and has co-edited 2 books and contributed 26 chapters. He was on the editorial board of Indian Journal of Urology and is a super specialty consultant in andrology to several organizations. He has conducted a highly popular annual andrology training program since last 20 years. Dr. Rupin Shah practices as a microsurgeon and a consultant andrologist at Lilavati Hospital, Mumbai. So it is indeed a great honor and privilege for me to present to you Dr. Rupin Shah. Over to Dr. Rupin Shah.
Thank you very much, Dr. Lal, for that very extensive introduction. And thank you, Anna OBGY Society, for inviting me to be part of your wonderful webinar series. Thank you, Dr. Swarupa, for taking that initiative. So, am I loud and clear? Somebody can just raise their hands.
Yes, you are good. So before we go, I just will like to urge all the participants to put their questions in the chat box so that sir will be taking the questions after he finishes his talk. Over to you, sir.
Sure, and maybe the rest can mute their mics to avoid accidental.
Yes, done, sir.
Right, sir.
Already done, sir.
So, I understand that our audience today is general gynecologists, obstetricians, not necessarily IVF specialists. So the talk will be targeted to such an audience. We're going to talk about practical things day to day. Maybe 10-20% of your practice relates to infertility. And what do you need to know about managing the male partner in such couples who come to you? So we will focus a lot on the basics, semen analysis, interpretation, what it means, and how to manage the commonest problem that you see, which is oligoasthenia. What you can do before you send the patient out. And when it comes to azoospermia, what are new things that you may not do, but you need to be aware of when you counsel the patient. So with that introduction, we'll start. The talk will therefore be in maybe 3 parts. First part is the semen analysis, understanding. The second part actually focuses on management of oligoasthenia, and the third part on azoospermia. So we're going to start with practical pointers, management of infertility, starting with the semen analysis. And it's strange that I have to show this slide, but unfortunately I do, as a reminder that when you see a couple, much before you put in every scope that you have into the wife, you should be asking for a semen analysis. And unfortunately, even today, very often I will see couples who come to me, one semen analysis done last week, but in the last 4 months, the wife has been extensively investigated. And then the semen analysis shows that he's azoospermic and everything goes topsy-turvy. So maybe 30 years ago, men were reluctant to give a semen sample, but today, with the very first prescription you're giving the wife for her hormone test, the man should be asked for a semen analysis. Abstinence 2 to 4 days, and why not more and not less? That's the abstinence with which WHO norms were established. From a practical perspective, when couple is trying for a child, we tell them to have sex every alternate day. So maybe 2 days abstinence is actually most representative of the kind of semen sample he'll be producing. Very long abstinence, motility will go down. Very short abstinence, count may go down, though actually in cases of very, very, very poor semen, it is surprising that in the IVF cycle, sometimes we will ask for a very short abstinence and we may get better quality sperm. Very important that the container should be a wide mouth container. Otherwise, they will spill the semen and we'll get a wrong report. Now, important practical point to bear in mind is that maybe 10% of our population, men, are not comfortable collecting by masturbation. So always when I ask them to give a semen test, I will ask them that, will you be able to collect a sample by masturbation in the clinic? And a lot of them will say no. And then we tell them, okay, if you can't masturbate in the clinic, will you be able to collect at home? And they say yes, and that's perfectly acceptable. In fact, in the COVID era, many of the labs insist that the sample comes from home. Or if you can't collect by masturbation, would you be able to collect with your wife's help, so half intercourse or even coitus interruptus, but making sure that they don't spill? And there's some who just can't collect, and for them a non-spermicidal condom, which is available from the people who supply IVF equipment. And then there is a group who just can't collect, and once you elicit that fact in the history, they can go to the uroandrologist who will give them a vibrator, which is a device like this, which will provide a strong stimulus to the undersurface of the gland's penis, and that will result in ejaculation. So you need to be aware of this because it's not common, but I've seen lots and lots of men over these many years where their entire therapy was at a standstill because they were not able to collect a semen sample either for analysis or for IUI or for IVF. So be aware that this problem exists, and it can be treated by a variety of ways that I just mentioned. And to date, I must have had to use the vibrator in over 1,000 men. So, of course, that's a specialized practice, but it's not uncommon. Now, once you've done a semen analysis, how do you interpret it? And this is very important because over the years, as you can see, the WHO parameters have changed. And unfortunately, many labs still lose old parameters where counts were 20 to 200 or 60 to 200 million, whereas today any count of more than 15 million is considered normal. The motility parameters have changed and morphology has changed dramatically, as we shall see. So because the lab itself very often doesn't list the latest parameters, you have to be aware that as per current parameters, which is based on a statistical analysis of 1,500 men, a count of 15 million per ml or a total count of 40 million with 40% motile sperm is considered normal. And very important, if you're having a good lab doing the semen analysis and following strict criteria for morphology, anything more than 4% is normal. And that is shocking because if I get a semen analysis from a good IVF lab and it says 90% sperm abnormal, it doesn't mean anything. But unfortunately, the gynecologist and the patient doesn't know this. And I get many worried men where either the gynec has told them 90% abnormal, that is why your wife is not getting pregnant, or that is why they're recurrent abortion. And the couple comes saying, Doc, am I going to have a two-headed baby? Because the report is showing double-headed sperm. Not at all. So once again, be aware that if a lab is following strict criteria, a normal sample, a fertile sample, may have as many as 95% abnormal. And I've seen many samples from IVF labs with 97, 98% abnormal, and the couple achieves a natural conception or an IUI conception. So one very important take-home message, who is doing the semen analysis? And in a good lab, don't worry about the morphology and don't let your patient get scared. Now, equally important, and this is going to be relevant when we talk about management of oligoasthenia, is to realize that there is a huge natural fluctuation in the sperm count, sometimes induced by the stock market, but otherwise even naturally present, you can see men are having counts almost heading to zero if you look at the last patient here, and then going up to 100 million. So these were 5 men who gave their semen samples weekly over a 1-year period. And you can see a huge variation. And very often, depending at which point the man has come to see you, he may be oligonormal or supranormal. And the next time he sees you, the count may change completely, not because of anything you've done, but just because of a natural fluctuation, what is called statistically as a regression to the mean. And therefore, another practical message to you, very often the patient is sent to me by the gynecologist, married. Show me your semen reports. He shows me the latest report, which is low. What about your other reports? No, the doctor told me only take the latest report. That's a big error. Because there is so much fluctuation, you have to look at all the reports. And if in the past most of the reports were normal and only the latest report is low, it may be a natural fluctuation. So always look at all the reports before labeling a patient one way or the other. Now, if that has been done, how do you interpret the semen report? And the first thing you look at is volume. And if the volume is less, the first thing I asked the patient was, did you spill anything? And often he'll say yes. And if he repeats the sample, it may turn out to be normal. Or the abstinence may be very short. He's abstained for 5 days. Because of that, he had a nocturnal emission at 4 a.m. and at 8 a.m. is given a semen sample. So if you have a report like this, 0.5 ml, 4 million, 20% motile, go into the history, and very often a repeat semen analysis may cure the picture. On the other hand, if it is low volume with azoospermia and fructose is absent, and he says, no doc, I collected properly, but I always get a low volume sample, then 9 times out of 10, even before I examine the patient, I know that this man has CBAVD, congenital bilateral absence of the vas deferens. It's very important because I get many patients like this. I look at the semen report, I know it's vasoplasia, and the gynecologist has just looked at the azoospermia but ignored the volume and told him, oh, this is very bad, maybe we might be able to aspirate sperm. The gynec already tells them about TISA and micro TISA and all kinds of horrendous things without realizing that low volume actually indicates a very good prognosis because it's probably obstructive azoospermia, usually due to vasoplasia, sometimes due to ejaculatory duct obstruction. Now, the second very common finding you will see is delayed liquefaction, 1 hour, 2 hours. And again, that drives everyone crazy, or viscosity very high. Now, these two are actually slightly different things. Liquefaction refers to the enzymes in the seminal vesicle and prostate. The seminal vesicular proteins coagulate the semen, and the enzymes in the prostate cause it to liquefy. Once it liquefies, then the constituents of the semen, which are again the proteins and the electrolytes, contribute to viscosity. Normally, after liquefaction, semen should fall drop by drop, but sometimes the contents of the seminal plasma are changed, and that makes the sample very viscous. So it's liquefied, but it falls like a big clump. Now, what is the significance of this? Well, either of these can be altered if the patient has seminal infection at present, or if he has past infection which has been treated. It is very common for the alteration to persist. Very often, however, it is idiopathic. The other consequence of this delayed liquefaction is that sometimes the lab can't do semen analysis because if the sample is not liquefied for 2 hours, 3 hours, they can't take a proper smear. And in that case, the lab is either to add amylase to liquefy the semen, or they take it up in a large syringe and then force it through a needle to liquefy. So that could be one problem, that they just can't do a proper semen analysis. If viscosity is very high, the semen analysis may be very misleading because they pick up a clump of semen, they can't mix it properly, so the sperm are not uniformly distributed in the sample. So if there's a very viscous semen sample, don't go by the sperm count motility reported, it may be erroneous, and try to repeat the test. Now, it also creates a problem with motility sometimes. How do you treat it? So if there is altered liquefaction and viscosity, look for other evidence of infection, history of urinary infection, history of testicular swelling, look for pus cells in the semen. And if that is present, you may want to give a course of antibiotics. Sometimes we give mucolytics, cough expectorants that contain bromhexine. Does it work? I'm not sure, but we give it for 10, 12, 15 days with the antibiotics and then recheck the semen. If the semen continues to show very delayed liquefaction, then maybe these are candidates where collection of a split ejaculate, sperm washing, and IUI may be better. On the other hand, if the sample shows delayed liquefaction, but after forced liquefaction it has good count, good motility, then don't worry too much, because when the semen sample is in vivo in the wife, there are also enzymes in the vaginal secretion which may cause it to liquefy. Now, impaired motility, again a very common problem. You have to distinguish between two groups of men. Those who have isolated motility problem, which means the count is very good, but the motility is poor, which may be 0 motility, 10% motility, or 30, 40% motility. And those men who have low count and low motility. If it's an isolated severe defect, which means count is normal, but only the motility is poor or very poor, these are usually congenital problems related to a defect in the spermatogenic process where the tail of the sperm is defective. So good count but isolated poor motility will usually not respond to therapy. On the other hand, it is low count and low motility oligoasthenozoospermia. Such patients can be treated with empirical therapy. So if it's total asthenozoospermia, you're trying to distinguish between Cartagener, which is live sperm but immotile sperm, which can be used for ICSI, or necrozoospermia, which are dead sperm, immotile sperm, where you can't use those sperm for ICSI, but instead you can take a testicular sperm, which is viable in these cases, and rule out and use those sperm for ICSI. Of course, always make sure that the sample was collected properly. Some patients collect it in a condom and then give it to the lab. Some have used soap or some kind of lubricant which has killed the sperm. Now, if it is moderate asthenia, 20, 30% with low count, then of course you treat it with all the medical therapies that we'll talk about. Similarly, low count, if it is isolated low count, motility is very good, only count is low, don't worry too much about it. But if it is low count and poor motility, then that is oligoasthenia, and the commonest cause is actually idiopathic. We can't find a cause, and we're going to talk about management of oligoasthenia. Varicocele, of course, we need to look at, and all of these we'll talk about in the next part of the talk. If the sample shows 1+ agglutination, it doesn't matter. If one sample shows agglutination and another semen report doesn't, it's not relevant. But if multiple semen reports all show a high degree of agglutination, then that may be an indication of either antibodies or infection. So then we test for both of them, but very often it is idiopathic. Now, when we test for antibodies, the problem is that the test available in most labs is an ELISA test. An ELISA test is done on the blood sample, on the serum, and it has no relevance to the diagnosis of clinically relevant antibodies. So the ELISA test, which is available from most labs, is actually irrelevant. And what we really need is a MAR test or an immunobeat test, which is not available in most of the labs. And therefore, antibody testing actually becomes irrelevant in most cases. And if there's too much agglutination, we just bypass the antibody testing and proceed to IUI. Of course, if there is infection, you can treat it. Now, this part is very important because very often you will get a semen report that says 20 to 30 pus cells seen, and you say, aha, this is the cause of the problem, and give the patient lots and lots of antibiotics, which in a lot of cases were not indicated. The reason for that is that a lot of reports of pyospermia are actually misleading. In the semen, there are 3 kinds of round cells. leukocytes, which you see to the left, which are actually due to infection. But there are also macrophages, which are normally present. They go about eating the dead cells. And there are spermatocytes, which are also secreted in the semen. Now, if your pathologist takes a drop of semen, puts it on a slide and sees it under a light microscope, he cannot distinguish between these three types of red cells, round cells. Only if he stains it like we see here with iosin nigrosin, or he puts it under a phase contrast microscope, can he distinguish between the three? And most pathologists don't do that. So if you have a report of large number of pus cells, you need to call up the pathologist and ask him, was this a sample which was stained? According to the WHO manual, he has to use peroxidase, and only those cells that stain positive with peroxidase should be counted as leukocytes. So if he's not stained it with peroxidase or HNE, then be very careful before you call this as biospermia. I've seen many patients diagnosed as biospermia, and when we send the sample to a good lab, the biospermia disappears and no antibiotics are needed. Finally, and we'll talk about this more in the question answer session, large number of abnormal sperm, as I see, usually it is just because the lab has used very strict morphology criteria. So don't worry too much about it. Now let's come to the next step, which is the management of oligoasthenia. And of course, you need to look at the sexual history, because sometimes that is the main cause. Look at history for stress factors that could be causing oligoasthenia. Take a proper history, and this is there in the textbook, so we're not going to waste time on that. Now, this is important. Ideally, every man who has an abnormal semen needs to be examined before you go further. I'm aware that most gynecologists do not examine the male partner. And that may be okay for the first 3-4 months of empirical medical therapy in a patient with oligoasthenia. But after that, somebody needs to examine the male. And ultrasound, and we'll talk about that later, is not a substitute for an examination. The ultrasound shows up many things which are not clinically relevant and may miss something. If you are one of those who examines a patient, having a Prader orchidometer is a very good idea. It will allow you to judge the size far more accurately than very often reported by the ultrasound. You can order it online. Online, it tends to be expensive. There are other sources which are much cheaper. Now, further evaluation, and we're going to talk about this as a repetition when we talk of oligoasthenia. Should every man have a routine hormone assay? And the answer is no. If the sperm count is more than 10 million, hormone analysis will be normal, no point in doing it. If counts are less than 10 million, then only should you go in for a hormone analysis. And this is again important because typically the gynecologist will ask for FSH-LH prolactin, because that is what you're used to when you evaluate women. In men, prolactin not relevant, only if there's erectile dysfunction or low testosterone. The first thing you want to ask for is actually FSH-LH and testosterone, and later on I'll show you why testosterone is so important, because FSH-LH by themselves are not adequate. They have to be interpreted in the light of testosterone. And the E2 you look at if the patient is obese and you suspect that there may be a lot of conversion of testosterone to estradiol. TSH, D3, B12, you can do it routinely because these are common problems nowadays. So this is the reason why testosterone is important. And here are two men. Both have relatively low FSH and LH. And of course, you're jumping up and down. Should I give them clomiphene? Should I give them HCG, HMG? What about aromatase inhibitors? And then you do the testosterone, and this is what pops up. The man on the left has low normal testosterone, but the man on the right has very good, in fact, high normal level of testosterone. So for the man on the right, the FSH and LH are actually low because of feedback by the high level of testosterone. His testes is very well stimulated and is in homeostasis. With the level of FSH-LH being secreted, testosterone output is excellent. This man needs no hormone therapy. On the other hand, the guy on the left, though the testosterone is low, FSH-LH have not gone up. So this is what we would call functional hypogonadotropic hypogonadism or relative hypogonadotropic hypogonadism. And the patient to the left may benefit from hormone therapy. So as you can see, the FSH-LH alone could be misleading unless interpreted in the light of the testosterone report. So very often people go in for a panel, they do free testosterone, DHE, DHT, and estradiol, prolactin for everybody, just a waste of money. The initial analysis, if at all, would be only total testosterone. Then to that you will add FSH-LH. Then to that you will add estradiol if the patient is obese. And if the testosterone is low and there is ED, then you will want to look at prolactin. But don't waste money by doing too many investigations or too few investigations. Now we already talked of antibodies, why the testing is usually irrelevant. And therefore PCT would be good, but most of the gynecologists don't do it. And therefore very often the test gets bypassed. One other question I'm often asked, Rupin, he has oligoastheno. I'm sending him for an ultrasound and then sending him to you. Please don't do that. As we shall see, the ultrasound is relevant only if the clinical examination is indicative of a varicocele. A subclinical varicocele is not of relevance and the ultrasound alone can be very misleading. So here are guidelines for both ASRM and AUA, the American Urology Association, who are saying that only palpable varicoceles may be causing infertility and should be corrected. And therefore, if you read the next line, ancillary diagnostic measures, which means ultrasound, should not be used for the detection of a subclinical varicocele in a patient who has no palpable abnormality, which means what comes first? The clinical examination comes first. And if a surgeon or a urologist says clinical examination normal, no varicocele, then if the sonologist finds a subclinical varicocele, that is not clinically relevant. And therefore, before the ultrasound, you would do the examination. Unfortunately, many surgeons and urologists also will write examination normal, refer for ultrasound. That's wrong. If the clinical examination is normal, the ultrasound is not relevant. So therefore, the first step is a good clinical examination, and you will ask for an ultrasound only if you're not able to do a proper examination because the scrotum is very tight, or you find a varicocele and now planning surgery, so you need to document the varicocele, you need to assess the severity, you need to know the other side, and therefore the ultrasound would be done. So the take-home message is it's not a substitute for examination, not required in every patient, and should be done actually only if the clinical examination indicates it. Now, one more carryover from the past is this tendency to do a testicular biopsy in men with severe oligoasthenia who are not improving, saying let's do a diagnostic biopsy, and doing it in every man with azoospermia. Both are wrong. There's no role for biopsy in a man with severe refractory oligoasthenia. The biopsy will not give you any information that will change the management. And the other way around, if a man has azoospermia, as we'll see when we talk of azoospermia, biopsy, single diagnostic biopsy has a very limited diagnostic role. And in fact, if we do biopsies, we do multiple and many biopsies. So don't rush your patients into biopsy. That was old-time thinking, no longer indicated in oligo and not indicated in most cases of azo. Now, what about specialized testing? Should you invest in a CASA if you have a large practice? CASA is fun. It gives you interesting data, but actually not clinically very relevant. This is a question I'm often asked. When should we refer the patient for a sperm chromatin DNA fragmentation test? And the answer is, it's an interesting test, but very often the result is variable. You do one type of test, you get one value, another type of test, another value. You change the lab, you get a different value. Some patients have high DFA and still achieve a pregnancy and vice versa. And for that reason, it's not a first line test. If it was very accurate, very reliable, very stable, rather than semen, we would just do DNA fragmentation for everyone. But there are still many, many questions, and therefore it's not the first test. A well-done DNA fragmentation is a very expensive test, and therefore we do it in those patients where there's idiopathic infection, which means husband is normal, wife is normal. There's no reason why she shouldn't be getting pregnant, and then we look at the DNA fragmentation. In patients who've undergone 1 or 2 cycles of ICSI and either didn't fertilize or had poor fertilization, or there was early pregnancy loss, there maybe DNA fragmentation could be playing a role, and those are patients that we would assess. What about reactive oxygen species? Well, it's an interesting thing to assay, but right now the assays are not available. But in future, we may actually be classifying men with oligoastheno as those with high ROS and low ROS. Only those with the high ROS would be treated medically. Vasography, truss, very specialized. Semen culture, common question. And many IVF units do semen culture routinely for everybody. Actually speaking, the evidence suggests it's not required unless there is some clinical marker of infection. So pyospermia, lots of agglutination, delayed liquefaction, already treated with doxycycline, didn't improve, then we may want to look at the semen culture, but not routinely. Now, at this point, actually, we're going to take questions at the end. But I'd like to take a break, Swarupa, if that's fine, just so that I can catch my breath. So I'm going to stop sharing the screen. And if there are any questions relevant only to semen analysis in the chat, we'll take that. Don't take questions on management of oligo and azo, because that's still going to take some time.
Right. So there are few questions in the chat box, not exactly related to semen analysis as such, but anyway, I think we will be anyway discussing them. So should I take them one by one? There are 2, 3.
Okay, let's start with 1 or 2, and if I think they're infringing on the next talk, I'll just move on to the talk.
Okay. So any specific indications for doing karyotyping? This is asked by Dr. Santosh Nikum.
Okay, very good question. You will do karyotyping in a patient with azoospermia and the small testes, very small testes. You will do karyotyping in patients with recurrent pregnancy loss. And you might do karyotyping in patients with severe oligoasthenozoospermia.
Okay. I think Santosh, that answers your question. Question from Dr. Panandikar, indications for doing testicular biopsy.
That will come when we come into azoospermia.
Okay, sir. And now, I think you have already discussed this about differentiating between pus cells and immature sperm cells. But somebody has asked it again. Sir, will you just repeat once? I think it was, differentiate between pus cells and immature sperm cells.
So that differentiation is very important, because often many reports that say pyospermia are actually counting the immature sperm cells. And the only way to do that is either to look at the semen sample under a phase contrast microscope or to stain the slide. So that is something that your pathologist would have to do. So if a routine sample says pus cells 2 to 3 per high power field, don't worry. But if it says 20 to 30 pus cells per high power field, then talk to the pathologist that had you stained the slide or were you looking at a wet prep? And that way you'll avoid a wrong diagnosis.
Okay. One more question. How would you label as mild or severe according to the count and motility? She's talking about oligoasthenoteratospermia.
So going by count, 10 to 15 is mild, 5 to 10 is moderate, less than 5 is severe. For astheno, again, 0% is severe or less than 10% is severe. 10 to 30% is moderate, 30 to 40% is mild.
Right, sir. and how to differentiate between dead and immotile sperm on semen
Good
analysis?
question. So a good lab, if they see that the majority of the sperm are dead, will either do an HOS test, a hypoosmotic swelling test, or the eosin-nigrosin test.
Okay.
The HOS test will distinguish between a sperm being live or dead with the advantage that it doesn't kill the sperm. So actually this method is used in the IVF lab itself. They have immotile sperm and they're wondering, can we use it for ICSI or not? So they'll do the HOS test. If the sperm is dead, the membrane hardens and it does not absorb fluid when the sperm is placed in a hypoosmotic medium. So the tail remains straight. If the sperm is live, the membrane is still semi-permeable. And when the sperm is put in a hypoosmotic medium, fluid starts flowing into the sperm and the tail starts curling because the membrane gets stretched. So the secret is not to wait long. In a few seconds, 30 seconds, 1 minute, just as soon as the tail starts curling, the sperm is picked up again and put back into a correct medium, which is osmotic match to the sperm, and the sperm again lets out the fluid and can be used for ICSI. The pathologist will instead incubate the sample with eosin nigrosin. Again, the dead sperm will exclude the stain, and the live sperm will pick up the stain, and that's how they'll know what percentage is viable.
Right. But sir, as you said, these are all very specialized tests, and probably if you are going to use that sperm, we need to do it in IVF lab itself.
Sure.
Like, okay. Now, I have a question regarding, especially for IUI, intrauterine insemination. When we have very low count, is there any importance of what is called as consecutive samples? I mean, nowadays people are talking about 2 consecutive samples at the gap of few minutes. So does that help?
So we'll come to that in oligo, but it's a good question. Consecutive samples help more when you have a very poor sperm sample and you're planning IVF. So if I had a man, first ejaculate showed only few dead sperm. Then a second sample may show a few live sperm, enough for ICSI. But if someone had a count of say 3 million with 10% motile, it's likely that the second sample will show another 2 or 3 million, maybe with 20% motile. And trying to pool them and do IUI may not work. It works if it's a borderline sample, because as we'll see later, there's no point doing IUI unless you can harvest at least 1, and some people say 3 or 5 million active sperm. So if you have a native sample with 1 million, 10% motile, you're harvesting very few sperm, and the second sample won't help either. But if the first sample has given you reasonable numbers, maybe just touched 1 million, then you feel, okay, let him give one more sample and I'll pool it together and maybe we'll get a better sample. Now the pro of that is, okay, with the second sample, you'll get more sperm to inseminate. The disadvantage is that the first sample is sitting in the incubator. And there is some controversy here. Some people feel that the time gap between processing the sample and IUI should be as short as possible to achieve pregnancy, in which case waiting for a second sample may not be good. Others feel it doesn't matter, in which case pooling the second sample may not matter. What is clear, however, is that the sample should be inseminated after you've confirmed ovulation, because after washing, the sperm don't remain motile for a long time. And if you inseminate 12 hours earlier and expect that the sperm will hang around and the egg will then come and meet the sperm, that may not result in success.
Okay.
So I think we'll move ahead with the talk now.
Okay, sir.
Okay,
That's fine. I think there are 2-3 questions. We can take them later.
Sure. I just need a break for 1 moment to get something and I'll join you. So I'm just switching off the screen for a moment. Okay, can you see me?
Yes, sir.
Sorry, I tend to get hypoglycemic when I talk a lot. I just needed to munch on something. So moving on to share screen. Am I audible clearly?
Yes, sir.
Now we are back to the second part of the talk. And that is, how do you manage oligoasthenozoospermia? And managing OAS is complex. Usually when I give this talk, everybody expects, okay, now we will hear which mixture from all the many medications that are available in the market is the one that we should be prescribing. The truth is actually all of them help, none of them help. It's quite controversial. And the management of oligoasthenia is actually more about understanding the couple, because as we will see, the same semen picture, two couples may receive very different advice. So the next 20 minutes, I'm going to try and give you, in fact, more an insight into the thought process that should be present when we are managing oligoasthenia. So the first question, of course, is, was it a proper sample? And we talked about this earlier. Does the lab follow the correct norms? Were proper sample collected? Was the patient recently ill? If a patient has had fever, then for 2 to 3 months, the semen sample may drop. So patient had dengue, malaria, COVID, comes to you a month later, sperm count low. Wait for a couple of months and it would improve significantly. Bear in mind that there's fluctuation. So look at multiple reports before you label a patient. Now, the next part is very important. And that is to understand that even if you have a well done semen analysis, it's only a rough indicator. It's not a very accurate indicator. That may be because eventually you need only one sperm. So even a poor sample, if there's one good motile sperm, may achieve a pregnancy. And two, and here all the ladies can nod, often a woman can compensate for a suboptimal male. And the same happens in fertility, as shown in this slide, that in the first 3-4 years of marriage, in fact, semen analysis is not predictive of which couples get pregnant. It seems that young fertile women can very often compensate for their subfertile men. And you will see this in couples who come for the second child. When you go back into the history, you will see that, okay, they just got married, sperm count was low, but she got pregnant. Now, 7 years later, they're trying for the second child. Sperm count is still the same, but now she's not got pregnant despite trying since the last 3 years. And what has changed is not the semen, but the wife's fertility. And keeping that in mind, we therefore understand that it is the age of the wife which may very often be important. This was a very interesting study on couples who underwent IVF-ICSI and failed, and then for 1 year did not have another cycle of IVF-ICSI. During that 1 year, 6% of these couples who had very poor semen still achieved a spontaneous pregnancy, and that was not attributed to the friendly neighbor. So how does this work? So here is a very old study, but still very relevant. And it shows that if you look at the left side, even if the motile sperm density is only 1 million, that's quite low. But if the couple has been trying only for a short duration, that's 12 months, there is still a 1 in 4 chance that the couple may achieve a natural pregnancy. On the other hand, if the sperm count is 20 times higher, 10 million actively motile sperm, but the couple has been already trying since 8 years, 96 months, their chance of pregnancy is only 14%. which means that time is perhaps the best filter and the best predictor about what is going to happen. If a couple has been trying for a long time, there is some subtle defect somewhere. Even if the semen looks normal, there's a problem. Even if the wife looks normal, maybe the tubal transport is poor. If there's a long duration of infertility, we need to get more aggressive. If there's a short duration of infertility, be conservative, even if the reports seem suboptimal. If you're looking at semen analysis, but also duration and the female factor. Another very important part in the history and examination is to identify both correctable causes, because if you can correct them, you may expect an improvement and therefore you should wait and not rush into advanced therapies. But also, are there irreversible causes? And this is important. Now, if a patient has come to me, sperm count is 2 million, but he says, doc, at the age of 7, I had bilateral orchiopexy, I would think that this man is lucky to have a 2 million sperm count, and I would not waste time giving him more medical therapy, because that is probably the best he's going to achieve. And the same holds true. He had mumps orchitis, or an examination, he has only 6 ml testes, or he has a YQC microdeletion. That is not going to improve. And even though the couple is young, married only 1 year, I know that this sperm count is the best output from the testes, and over the next 10 years, it will probably drop to 0. So in such cases, in fact, the opposite advice, rush into IVF-ICSI as soon as possible. And therefore, you have to look at multiple things while trying to take a decision about whether you should treat the patient immediately or not. So here are 2 men or 2 couples, same type of semen picture, 10 million sperm count, 30% motile. But one couple to the left is young, married only 2 years, have not had much treatment. This is a couple where we would certainly want to give medical therapy and buy time. Tell them, don't worry, over the next 1 year, we'll do the best we can. We'll improve the male general health. We'll give other medication. We'll ensure that the wife is optimally fertile. We'll tell you what is the best time to have intercourse. And 1/4 to 1/3 of these couples will achieve a natural pregnancy. On the other hand, if you have a couple on the right, just because they have come to me for the first time, doesn't mean that I should waste another 6 months giving them medical therapy. They've been married long enough, they've already received therapy, their wife is 35, her ovulation is now going to suffer. Don't waste time in this couple, immediately let them proceed for ART. So you have to look at the totality of the couple. Now, in terms of treatment, do therapies work? We saw earlier the concept of relative hypogonadotropic hypogonadism. If it's severe hypo, FSH 0.3, LH 0.3, testosterone non-detectable, that's a different group. They require years and years of FSH and LH before they get sperm. But men with oligoasthenia and low normal FSH, LH, testosterone, they may respond to hormone therapy. In our patients, we have a subgroup of people with tropical conditions, chronic filarial epididyma orchitis, lax hydrocele, thickened epididymis, thickened scrotum, history of testicular swelling. In such patients, with a course of antifilarial followed by anti-inflammatory, maybe a short course of steroids, sometimes show dramatic improvement. Accessory gland infection, genuine pyospermia we've spoken about, them we could treat. So how do we treat such men? If there's genuine pyospermia, then before doing a semen culture, I first give doxycycline for 20 days to get rid of the chlamydia and mycoplasma, which are often present and hard to culture. Then recheck the semen. If the pus cells have gone away, that's it. Make sure that the wife is also treated. If after giving doxy, the pus cells still persist, then we will do a semen culture with a lot of precautions, which means cleaning the glands with betadine, cleaning the penis, asking him to pass urine, and then doing a semen culture. And then we will give antibiotics as per the semen culture. Anti-sperm antibody is very controversial. Most patients just wind up with IUI right away. Now, what about varicocele? Man has oligoastino. We've already said if there's no clinical varicocele, don't look for a subclinical varicocele. But if there's an obvious varicocele, grade 1, 2, 3, but clinically obvious, with confirmation on Doppler, then what do we do? Now, varicoceles are strange creatures. Some men may have varicoceles and yet have normal counts. Some men may have low counts and a varicocele, but the varicocele may not be the cause of low count. And in some men, there may be low counts and a varicocele, and when you treat the varicocele, counts may shoot up. So, prognosis is variable. The current recommendation is that if there's a clinical varicocele and the couple has been trying for an adequate period of time, and the female is fertile, not having tubal block, and the semen parameters are abnormal, then it is justifiable to advise surgery, which also means that you should give the couple an adequate trial. If the couple has been trying only 6 months, you can't really say they've had an adequate trial of treatment. Don't do an ultrasound if clinically it is normal. If there's a clinical varicocele like this, we will do a Doppler or ultrasound to see whether there's reflux on the right side. And in that case, if there's a left clinical varicocele and right subclinical varicocele, then we will operate on both sides. My practice, therefore, is to first give a trial of medical therapy, since in many cases, men will actually improve on medical therapy, or the mere fact that we are giving them time will allow them to achieve a pregnancy. But we give them a timeline. We tell them that, okay, you have low counts, you have a varicocele, we're going to give you medical treatment. Every 3 months, we will check your semen. If in 3 to 6 months there's no improvement and there's no pregnancy, then we will treat your varicocele. There's a 60% chance that after varicocele surgery, the sperm count will improve and there'll be a pregnancy. And in 6 months, there's no pregnancy, we'll do IVF. If at any point we tell the patient, you feel impatient, want to jump the medical therapy, go in for varicocele surgery, or jump the varicocele surgery and go in for IVF, even that is acceptable. So with that timeline, some will take medical therapy, some will directly go in for varicocele surgery. And there are many who say, forget the surgery, we want to do IVF right away. If we treat the varicocele, the best way to treat it is by a microsurgical subinguinal varicocelectomy, because that gives us the best control on the testicular artery, allows us to tie off all the veins and prevent any post-op hydrocele. Now, there may be more questions on varicocele, and we'll take that in the question answer session. But here is the big question everybody has. Which medical treatment should I give to a man who has oligoastino, does not have a varicocele, has been labeled as idiopathic? Lots of treatments are available, either individually or in combination. Some of them are quite expensive. Which one of these works best? Now, if you go through studies for each component, you can find some studies showing that they work well and other studies that show that they don't work well. So, understanding that, if you look at the meta-analysis, what it says is that empirical use of antioxidants in a large population will produce some benefit in terms of pregnancy rates. Who is the correct candidate? We are unable to identify. Which antioxidant is best? We are unable to say. Should you give the treatment or not? Therefore, it depends, as we said, on age of the couple, duration of infertility, etc. If it's a young couple, short trying time, then certainly we would like to buy time using empirical medical therapy. Older couple, maybe we won't waste time. So we don't waste time, we don't waste money. Which treatment do I give? If I have a patient from the lower socioeconomic class, one, I don't want to give something that will cost him 4,000 to 5,000 rupees a month. So I don't give the expensive preparations. And two, I suspect many of them may be nutritionally deficient. So what I give them is a inexpensive multivitamin with lycopene and vitamin E, all of it should not cost more than 10, 15 rupees a day for 3 months. And I tell them that it will take that much time for improvement and come back with a semen report, and then we'll decide whether to continue. And to my surprise, a lot of these patients improve quite a bit with just multivitamins and antioxidants like lycopene and EBR. If I get a patient from a higher socioeconomic class, assumably better nourished, and who can afford more expensive treatment, then those are patients where I might give any of the numerous combinations that has coenzyme Q10, carnitine, and then everything else, selenium and this and that and that. And that depends on your choice that particular month. Some of them will benefit again. What is important is to tell the patient that it takes 72 days to make sperm. And therefore, it is important that you try during this period, but after 70, 80 days, do a sperm test and meet me so that we can decide whether to continue the medicine or change the medicine. So, as I said, if the counts are more than 10 million, you can give either multivitamins or CoQ carnitine. And if the patient seems like they'll follow advice, we emphasize lifestyle changes. Some data showing that regular exercise, proper nutrition, all of which can improve the lifestyle. This is not a good prescription because the treatment is given only for 1 month, and then the patient was told to come back with a semen report. What happens is he'll come back with the semen report, but when there's no improvement, both he and the doctor will conclude that this medication was ineffective, which may not have worked simply because the duration was not long enough. So ensure that you give the treatment for an adequate period of time. At least 2 months, maybe 3 months, depending on whether the couple seems impatient or not. Now, the hormone profile we've already discussed. Let me repeat it because it's important. So here is a man, his sperm count is 5 million, motility is 20%. Maybe he's already taken some vitamin E, multivitamin, not benefit. Here is where I would first do a hormone analysis. If he can afford it, FSH and testosterone and LH. If he can't afford it, testosterone alone. If testosterone is more than 400 nanogram per decimeter, that means the testis is adequately stimulated and we don't need any hormone therapy, we don't need any further hormonal testing. On the other hand, if the testosterone is low, 230, 250, less than 300 nanogram per deciliter, then we would look at his FSH and LH and maybe his E2. If testosterone is low and FSH LH are high, very high, 1.5 times, 2 times normal, then we know that this is a stimulated testis, but he has testicular failure, and therefore FSH LH are high, testosterone is low. If testosterone is low and FSH LH are also low normal, then I tend to give clomiphene 25 milligrams daily for 3 months. You could alternatively give HCG, HMG, but that's a lot more expensive and may not confer any benefit. If there's the same picture, low testosterone and FSH LH are low, but the estradiol is very high, and the testosterone estradiol ratio is disturbed, then one may choose to give an aromatase inhibitor. That will prevent the conversion of testosterone to estradiol, thereby stopping the negative feedback, thereby raising the FSH and LH, so that the patient's FSH and LH will go up and the testosterone level will go up. And then check the report again after 2-3 months. So this is just an example of the TE ratio. So here is a man whose testosterone is 2.66, which is 266 nanogram per deciliter, divided by the estradiol, which is in the normal range, but high normal, expressed in picogram per ml. The testosterone divided by the estradiol is 7. Normally, the ratio should be more than 10. So this is a patient where we would use anastrozole to see. What about external gonadotropins? Can we give that? Yes, but they're more expensive, more tedious. Therefore, it's my second choice. Isolated medical therapy usually doesn't work. Now, sperm washing. Surf excel hai na, dho dalo, dal do. It doesn't work for male factors. Many studies have shown that unless you meet a certain threshold, which means initial counts of at least 10 million, 30% motile, or after a harvest at least 1 million motile sperm, pregnancy rate will be only maybe 3 to 10%, and a cumulative pregnancy rate of 15 to 20%. So that's quite low. And therefore, it is not a good idea to waste too much time and money treating pure Moore factor infertility by IUI. ICSI will work in all these cases. And sometimes people wonder, extreme territory, should we do ICSI or not? As long as you can get a few normal looking sperm, doesn't matter whether they're motile, immotile, if they're viable and the head is normal, ICSI can be done. So once again, we'll stop here and take questions related to management of oligoacidemia.
Yes, sir. So somebody has asked whether is there any medical treatment for varicocele?
There's no medical treatment to cure the varicocele, but varicocele acts by impairing the HPT axis, increasing ROS in the semen, increasing the local temperature.
Right.
Conservative treatment of varicocele would mean I would normally give them clomiphene, either daily or alternate day, give them some antioxidant and ask them to cool their testes 2-3 times a day. That would be the medical management to improve semen in a man who has a varicocele.
Okay. Sir, one more question is, what is better, a progressive sperm or just a motile sperm?
Ideally, we should have progressive sperm. Now, this is one of the controversies with the latest WHO parameter. The latest WHO has done away with the distinction of grade A, grade B. They should just be progressively motile and they're clumped together. The reason why they did that is they felt that many labs, the technician was not trained well enough to distinguish A and B. But many people have criticized it, and even I don't agree with them. I think the subpopulation of active rapid sperm is important.
Okay. Dr. Panandikar had asked interpretation of estradiol in obese oligospermic men, but I think you have already answered that. Yeah. So do you want to take that question of testicular biopsy now, or you will take it later? Okay. And I have one question, since we have spoken about antioxidants. Sir, I have seen patients being on antioxidants for ages together, and like as a reactive oxidation species is not very good, but I understand there is some amount which is actually necessary for development and capacitation. So is there any time limit that antioxidants can be given only for this many time, this much of duration?
It's a very good question, because there is something known as, what do they call it? Something that indicates infertility because the ROS is too low. You're absolutely right that normal levels are required. And that is why sometimes if you're giving antioxidants from a normal ROS, you may actually harm them.
Right.
So, too many antioxidants or for too long, not a good idea. People sometimes think, "Arey, ye bhi de do, ye bhi de do, ye bhi de do." And I see patients taking 2 or 3 different preparations all together. Sometimes because they've consulted 2 doctors, they feel we'll mix up the medicine from both. And that may actually be harmful. Antioxidant should be prescribed in limit, and maximum time in 3-4 months. If it hasn't helped, move on to the next level.
So by and large, you will say that around 6 months is good enough for all the medicines to
Correct.
act?
Fair enough. If it doesn't act, you need to do something else.
That's right. So Dr. Rajneesh Patel has a question. What is the cutoff to recommend a IUI as far as motility and sperm count is concerned? Like with this much of count, you can still recommend a IUI.
Ideally, you should look at what you recover after doing a sperm wash. Some men, you may have a good count, the motility is poor and therefore harvest is poor. Some men have a low count, but motility is good, you recover more. So at least 1 million active sperm after harvest. That was according to the study I showed you. But many people feel that 3 million active sperm or 5 million active sperm should be recovered before you do IUI.
Okay, sir. Sir, you spoke about anastrozole. I want to know, I think we can use even letrozole since that is easily available. So, sir, what is the dose of letrozole when we are treating, especially with low ratio? I mean,
so letrozole is 2.5 mg and anastrozole is 1 mg.
2.5 milligram every day?
Yeah, so that's what I'm coming to. The important thing is don't give it every day because men also need estrogen.
Okay.
They need it for libido, for bone, for general drive. So giving too high a dose is also harmful. You give anastrozole every alternate day or letrozole every alternate day. And then reassess the T ratio and the other hormones after a month and a half of therapy.
Okay. Now the question is dose of gonadotropin for oligoasteroteratospermia.
So provided it's a relative hypo-hypo, which it would be because if there's oligo-terato, that means gonadotropins are at work. Maybe they are a little low. So there, I would actually give clomiphene rather than a gonadotropin. But if I have to give a gonadotropin, 5,000 units HCG has a half-life of 5 days. So you can give it once a week rather than giving him 2,000 every alternate day, which makes it twice a week, which increases the number of injections to 2 men. And with that, you would give HMG, that would be 75 units twice a week, and check the result after 2 to 4 months.
Okay. For IUI with the count of 1 to 2 million, is there any specific method for wash?
Yeah, there are many methods, and when the count is very low, a simple swim up won't work. Preferably a density gradient should be used. If you're preparing a sample for IVF, then there are even newer techniques like microfluidics, etc., which could be useful. But I think it's important to remember that when you're doing IUI for male factor infertility, it's important that a good lab processes the sample. If you're doing IUI for, say, cervical hostility, you'll probably get away with a simple swim up that most people can do in their clinic. But when it's male factor infertility, how the sample is handled becomes very important.
Okay. Sir, question by Dr. Panandikar, role of astaxanthin as far as male infertility is concerned.
Astaxanthin, very, very, very potent antioxidant. I've read very few studies on it. And the reason why I'd like to see more studies is, as we were discussing earlier, too much of antioxidant activity may also have the opposite effect. Is astaxanthin practically good or bad? I'd like to see more studies. Theoretically, it's good. I'll move to the last part of the talk now.
Okay, sir.
For that, I need to open another presentation. So, I think the problem is that since that is not open, I've not kept it open, and therefore it's not linking to the Zoom. Let me see. I may have to actually disconnect and reconnect after opening
I think yes,
the
sir,
other
you should
presentation.
leave and join
I'll
again.
leave.
मोनाली सर आ गए हैं, होस्ट बना दीजिए उनको, co-host.
Yes, yes. I have done.
I
Yeah.
hope everybody utilized their very short bathroom break. Got your popcorn and your coffee, and we're ready to continue. So now we'll go on to azoospermia. This one's not maximizing. I'm going to try to disconnect again and see because it's here. Are you seeing half of the slide?
Yes, sir.
Click on the slide and then.
Yes, sir.
Click on the center slide.
I clicked on the center slide. Now let me see if I can maximize. No, it's kind of frozen there.
Or sir, go to slideshow and start from the beginning. On the top, go to
This is
slideshow.
it's not responding. Maybe I'll have to open it again. Oh, see, it's kind of frozen.
Sorry, you can stop screen share and then you can restart again screen share.
Despite our best attempts, sometimes
Right, sir.
technology, it's forcing me to this. I had two presentations open because I wanted to take something from both. Okay, I'm going to disconnect again and open only one presentation. So for those of you who couldn't make use of the last tea break, we have another 2 minutes.
Sir, please log out and log in again.
I'm there.
Monali,
Yes,
Monali.
sir. Yes, sir. बोलिए. Yes, come.
हाँ, सर को बोलो to share the screen again.
Yeah.
होस्ट बना दो, co-host बना दो.
सर को co-host बना दो.
बना दिया. Dr. Rupen.
Yeah. For some reason, this one is refusing to
Full
open.
screen.
It's not going into full screen.
So double click on your slide first, number 1.
It's not even advancing.
Okay.
I think I may have to restart completely. So now you genuinely have a long tea break. Sorry, everyone, we've
Sir is there.
Many a times this laptop cache doesn't allow you to do that, and because of heavy traffic. So many a times you have to restart it or give some rest to your laptop. It also depends laptop heat kitna hai. So base on which it is already put in, very important. Put on that. Very important. Such issues are very common in laptop, not the desktop actually per se.
So Vojit, has he logged in?
I'm there, sir.
Has Dr. Rupin Shah logged in again?
No.
Not yet.
Because he's right. He's probably restarting his laptop. Even latest, fastest, sharpest of technological innovations have their own limitations. So
No, but up till now, it was going on smoothly.
yeah, sometimes, sir, it happens, sir. And a week back or so, 10 days back, Dr. Kriplani madam was actually, we were having a webinar. She was a speaker. So not able to actually screen share her one of the slideshows. And it took almost 20 plus minutes to restart. And it was just because of the position of that a particular folder, it was not allowing her to start. So
Sir, meanwhile, should I just fill in some time giving some tips to improve sperm parameters in oligospermia so that?
Yeah, we will utilize that time. Yes.
Dr. Rupin has.
Aisha sir has come.
Yeah, sir has come.
Okay.
Okay.
Yes, sir, clear.
There's this very famous movie called Patton and General Patton in the US. And there was a war going on and all these tanks were coming and one tank came and got stuck in the middle. Best they tried, it wouldn't move. And General Patton comes and with his baton gives it a hard whack. And he says, anything mechanical, give it a bang. And the tank started. So that's what I had to do to the computer. So now we're ready to talk of azoospermia. Now, unlike oligoasthenia, which I feel can certainly be treated initially by the gynecologist before referring to a urologist, azoospermia, I feel, is an area that needs specialized care from the beginning. So my message for azoospermia would be that refer the patient, but you need to understand what is possible because often your surgeon himself may not be very familiar with what needs to be done. And if you have an understanding of what is possible, you'll be able to guide the patient correctly. So in the next 20 minutes, I'd like to clarify misconceptions about the management of azoospermia rather than tell you how to treat it, because the treatment is very specialized, which would be relevant to only a few in the audience. So here is the first misconception, that many practicing gynecologists who are not infertility specialists have, they see a report azoospermia, okay, nothing can be done, let's recommend donor insemination. So here was one gentleman whom I saw after 7 years of marriage. He'd gone to several gynecologists. They looked at his sample, oh, only 0.8 ml azoospermia, 0.5 ml azoospermia, nothing can be done. I think they even tried a couple of cycles of donor insemination. And then he came to me. This was actually, I think, at a camp somewhere in Punjab. One look at this report and we knew that the diagnosis was actually bilateral vase aplasia. And sure enough, when we examined the patient, it was CBAVD, and all he needed was simple PSA, percutaneous epididymal sperm aspiration, and IVF became possible. So just because you see a report of AZO, don't jump into a diagnosis of nothing can be done. On the other hand, the second approach is that which comes from the IVF specialist, who believe that, oh, any case of azoospermia, no problem. We'll aspirate the sperm and we'll do ICSI. So their approach is for every case ICSI. And that may also not be the best approach. So here was a 30-year-old male, azoospermia, good volume, good size testes, turgid head of the epididymis, clinically a block in the tail of the epididymis, diagnosed as having clinically obstructive azoospermia. 1 year after he met me, he sent me this email, and we'll read it bit by bit. But in the middle, you can see he says that I went to all the doctors in Mumbai, suggested me IVF ICSI, and told me that VEA will not help. However, he was desperate to have his own child normally, and somehow, despite the best attempts of the IVF specialists, came to us, and we did a microsurgical vasoepididymal anastomosis. You can appreciate how thin the tubule to the left is the epididymal tubule, to the right is the vase. The methylene blue stain delineates the mucosa, and you're using 10O ethylon, very, very, very fine, to join the two together. So after this procedure, this is what happened. He's written that 6 months after surgery, my count is now normal and motility is 10%. After 8 months, the motility was 15%. And now I'm glad to inform you that my wife is having a normal pregnancy. And I really thank you from the bottom of my heart. Now, what happens to IVF specialists is that they get so focused on somehow achieving a pregnancy that they forget that for any couple, and especially for the male, being able to achieve a pregnancy naturally is very important to his sense of self-worth, to his confidence as a man. They will accept IUI IVF if no other option is there, but at some level they would always prefer to do it naturally. And sometimes failure to do so may have major consequences. This was a Jawan posted all the way in the Northeast who came to me after his second marriage. Now what had happened is he had got married a few years ago. He had a semen report of 0.2 ml azoospermia fructose negative. Looking at that, the gynec, they told him, no chance naturally. Let us try to aspirate sperm, and if he gets sperm, we'll do IVF. So he underwent one cycle of IVF, it failed, and his wife divorced him, saying that you're incapable of making me pregnant. I even did this difficult IVF, so I'm leaving you. Then he got married again and rushed on special leave from there all the way to us. And you can see massively dilated ejaculatory duct, dilated seminal vesicles. This was a case of ejaculatory duct obstruction. Very easy TUR, transurethral resection, to de-roof the cyst. And at 2 weeks follow-up, his count was 61 million. Unfortunately, I never heard whether his wife got pregnant, but very likely she did. And had this man been advised correctly the first time, his first marriage need not have ended in a divorce. So the second message, which is actually for IVF specialists, is that even in a case of obstructive azoospermia, ICSI is one option, but there may be other options like reconstructive surgery. And you have to give the patient a choice. Now, he may go one way or the other, but the choice is important. Now, if we have surgeons in the audience, these are the pros and cons in a man with obstructive azoospermia due to a block in the epididymis. Microsurgical VEA is a good option because it can result in a natural pregnancy. 60% chance of successful surgery, 1/3 will achieve a natural pregnancy. It's less expensive than IVF and doesn't put any burden on the wife. On the other hand, IVF, the result is much quicker because after VA, it may take a long time for pregnancy, and IVF doesn't need any surgery on the husband. Practically speaking, if you have an older couple in their 30s, late 30s, poor ovulatory reserve, or who have been infertile for a very long period and now are quite desperate, there we would recommend ICSI. But if it's a younger couple, then IVF is an option. Now, the third misconcept that many gynecologists have is that, okay, patient comes to you, he has azoospermia, and he has one
Hello. Some problem with Sir's net.
Okay, it is back.
Any problem with
No.
presentation?
No.
Now we can hear you, sir.
Now we can hear.
Okay. Yeah. So, did you miss anything? Do I need to go back?
One slide.
Okay.
So one slide back will be good.
Sure.
Yeah.
So this is the third misconception, that often a patient will come to you with azoospermia and the testicular biopsy report, one biopsy done, which shows sertoli only or atrophy or complete maturation arrest. And you tell the patient that, oh, nothing can be done because your biopsy is terrible. Now, in the past, we used to believe that either a man had no sperm in the testes, which was primary testicular failure, or he had lots and lots of sperm, but he was azoospermic because of obstruction. We now know that there is another group of men who don't have obstruction, who have a few sperm in the testes, but they're still azoospermic because the number of sperm in the testes are very few, and these few sperm do not come out, they get destroyed in the epididymis. So it is this middle group that is very interesting, because in such a group you could have a biopsy like this. You can see most of the tubules are uniform hyaline. So this would be a man with a small testes, half the normal size, FSH maybe twice normal, went to a general surgeon, he did a biopsy which he shouldn't have, and the biopsy report came back as testicular atrophy. And you tell the patient nothing can be done. But if you examine this biopsy carefully, look all the way at the bottom of the picture, and you can see one tubule with multiple layers of cells, and that is a tubule showing normal spermatogenesis. So there are many men with testicular failure who still have patchy areas of spermatogenesis. So maybe 1/3 of men with maturation arrest, 1/4 of men with sertoli only could still have a few sperm scattered around the testes. So if a single biopsy is not predictive in a man with non-obstructive azoospermia, why do that biopsy? It will only create more confusion, and therefore single diagnostic biopsies are no longer recommended in men where we suspect this is non-obstructive azoospermia. If it is a case of suspected azoospermia, and before doing reconstructive surgery, you want to prove that sperm are there, then one may do a biopsy, but that's only a small group of patients. In the majority, we would not do the biopsy. So that dovetails into this, that neither FNAC nor testicular biopsy is a good method to evaluate azoospermia. It's good in a case of obstructive azoospermia, but not good in non-obstructive azoospermia, which constitutes 90% of the azoospermics. Because especially a patient to the right who has testicular failure with few areas of sperm production, you would need many, many, many biopsies before you hit that sperm by chance. And usually you do 1 or 2 biopsies not find sperm, and then the doctor and the patient would be discouraged. So here is one study that shows that you may need anywhere between 2 to 10 biopsies in men with maturation arrest or Sertoli cell syndrome before you can get sperm. So in fact, this was a paper that won the best paper prize at the ISAR 2 years ago at Agra, where they took men up north. FNAC is very common. In our region, surgeons tend to do more biopsies, but up north, every azoospermic, they do an FNAC. And once FNAC doesn't show sperm, they tell the patient nothing more can be done. So these were men who had azoospermia and whose FNAC did not show sperm, and who then underwent what is called as microdissection TSA, which is a technique in which the testes are split open, and under the microscope we look for good areas which might have sperm. And you can see that in 46% of men where the FNAC did not show sperm, we were able to find sperm and achieve a pregnancy in 41% of the total group. So that's quite dramatic in men who had been told that they have no hope at all. Here is another case, a far more difficult one. Mumps orchitis, testes 8 ml, that is 1/3 the normal size, FSH very, very high, testosterone very low. And twice people had done TISA, which means with a needle they had tried to aspirate sperm and got no sperm. So even we were not optimistic. We told him nothing can be done, but he still opted for a microtesting. And when we split the testes, this is what you can see on the left side is only jelly in the testes, and that is why the biopsy didn't reveal anything. On the right side, you can see a half where we've dissected through the jelly, and a few areas with tubules are seen, thin tubules, but when we pull these out, from these bad tubules, we could get a few motile sperm, enough to do IVF ICSI. So in men with non-obstructive azoospermia, there's no point in doing a single biopsy or an FNAC because they will need a TISA or a micro TISA before sperm can be found. Another common misunderstanding in an azoospermic man is, okay, azoospermia, but FSH is normal. That means we'll get sperm, right? Wrong. Half of the men with azoospermia and normal FSH, you may not find sperm at all. And on the other hand, very often the gynec tells me, "Arey, FSH bahut high hai." That means we won't find sperm at all. Not true. Even in very small testes with high FSH, it may sometimes be possible to find sperm. So here was a man with a very tiny testes, literally the size of a pea. FSH was 80. It already adopted a child and then came to us. And you can see the testes, they're really, really tiny. When you open the testes, out pop fat tubules. And from these fat tubules, we could recover enough sperm to produce 3 embryos here seen on an embryoscope. One of the 3 embryos resulted in a viable pregnancy and the birth of a boy child, a girl child. The remaining sperm were frozen. We underwent a second IVF cycle with the frozen sperm from the tiny testes. There was no pregnancy, and the third cycle resulted in a baby boy. And all that from the tiniest possible testes. And a lot of studies have now shown that in azoospermia, whether sperm can be found by micro-TISA or not, cannot be predicted by FSH or inhibin or testicular size or even age. You just have to do the procedure to find the sperm. But it's a procedure that you cannot keep on doing, and therefore it is important that any sperm found during such a procedure should be frozen in the IVF lab so that that sample can be used when the eggs are retrieved. So this was then the few concepts about azoospermia that I wanted to share. You can see the circle going around, that slide is hanging. I'll see if I'm able to stop sharing. Yeah, we'll take questions and then I'll try to go back to the last 1 or 2 slides if possible. So any questions about azoospermia?
Right, sir. First question is, how do we go about counseling the patient when we are doing micro TCA or TCA before IVF?
So very good question. The two ways in which we counsel the patient. Now, that's where here you have to involve the expert who will look at the testis size, the epididymis, whether it's flabby or turgid, the FSH, the past medical history, and tell you this is most likely obstructive, which means 80–90% chance that I will get sperm, or this is definitely non-obstructive, which means on an average, a 1 in 3 chance that we will get sperm. So if it is non-obstructive, we'll tell the patient that, see, clinically, based on 1, 2, 3, 4, you do not have blockage, you have non-obstructive azoospermia, and medical therapy will not help you, surgical therapy will not help you. However, we can retrieve sperm from your testes and use these sperm for IVF. Chance of getting sperm is only about 35%. So now, how would you like to do it? We can first do the sperm extraction, freeze the sperm, and then stimulate your wife, which is good because if you don't find sperm, your wife will not need stimulation. The disadvantage is that if you take your sperm and freeze them, they may or may not survive for the actual attempt, because in 10–20% cases, if you have very few sperm, they may not survive the freezing. In which case we'll have to repeat the procedure. And if it was a very difficult procedure the first time, we may not get sperm the second time.
Right. So question similar or related to this, should the egg retrieval be done before sperm retrieval or vice versa? I mean,
so therefore, continuing the first one, we tell the patient that one option is we'll freeze the sperm and then stimulate your wife, or the second option is we'll stimulate your wife, and on the day of her pickup or 1 day before her pickup, we'll do your TISA, micro TISA, and if you get sperm, we will use them on your wife. And if you don't get sperm, then either your cycle is wasted, or if you're willing for donor sperm, because there's no other option, then we'll immediately use the donor sperm so the eggs are not wasted. So what happens is that if a patient says, Doc, we want the best possible chance, we don't care about the money, we don't care about failing, then we would tell them your first attempt is always your best attempt, and we will combine the sperm retrieval with the egg pickup. If the patient says putting in so much money into IVF and maybe I won't get sperm and we don't want donor, then we tell them, okay, we will first do the sperm retrieval, and if you don't get sperm, you don't go ahead. If you get sperm, we go ahead. Now we tell them that we have two techniques. We have the TISA where we will aspirate sperm with a needle, and we have micro TISA where we will cut open the testes. If the testes are very small and fibrotic, we tell them there's no choice, we will definitely have to do micro TISA. If the testes are good size, we tell them initially we can try TISA. And if TISA doesn't work, then we will do the micro TISA all at the same session. So we plan for both. Start with the less invasive, and if you don't get sperm in that, then go in for the second technique.
okay. Question by Dr. Panandikar, why are the results of donor IUI are poor? And
see, donor IUI is trying to mimic natural pregnancy with a sample which nowadays has to be frozen thawed. So in some cases, the frozen thaw sample may not be what the lab claims it to be. So ideally, even if you get a prepared sample ready to inseminate, you should have a simple microscope in your clinic and put one drop of the sample on a slide and inseminate the rest. And sometimes you will find that the sample was not good, and that is why the IUI did not work. The second, of course, is when I counsel patients for donor IUI, I warn them in the beginning that this is like natural conception, just like a couple may take 3 months, 6 months, 1 year of marriage before they conceive. The same will take place when you're doing donor IUI. So mentally be prepared for 3 to 6 cycles, because otherwise 1 or 2 cycles fail and the couple gives up. So both the doctor and the patient should be aware this is just marginally better then natural conception, because you're timing it more accurately. And that means maybe a 10 to 15% chance, maybe 20% the first time, 15% the second time. So that cautious counseling should happen. And remember to check the sample.
Right. And if we are using donor samples, sir, is it important to do it 2 times, like in 2 days, 2 different days, 24
So
or
again,
36 hours?
controversial. And that actually is something that can be answered by the IVF specialist. So the other day I heard a talk by Jatin Shah. We were doing a symposium for the TAPISA, that's the Tamil Nadu Society. And what slide Jatin showed was that when you're doing IUI, it's most important that the egg should already be released. So if you're timing your IUI such that the egg has been released, 1 insemination is enough. Trying to do 2 to bracket it may be unnecessary, and it will just add to the cost. But if you're not sure when she's going to ovulate and you're doing it blindly, then maybe 2 is good. But if you're monitoring the ovulation, triggering, timing it, then 1 sample post-ovulation would be ideal.
Right. One question is, if we don't get sperms by TISA and don't have facilities to go for micro TC, can we do on the other testes TSA same time?
So what happens is if you do TISA, which means you take 7-8 biopsies, you do cause a suppression of spermatogenesis. So if a patient has had a negative TISA and comes to me for micro TISA, I insist that they wait at least 6 months before I take them for the micro TISA. And if you are a center that does not have facility for micro TISA, here are some clues. If the testis is very small, if FSH is very high, do not do the TISA. It's very unlikely to succeed.
Okay.
That patient directly has to go to a center that has micro TISA. If the testis size is decent, FSH is normal or marginally above normal, there the success with TISA is only marginally inferior to micro TISA. In such patients, you are not doing an injustice to them by doing only the TISA.
Okay, sir. The question is, preparation of IVF sample, how should we calculate per oocyte?
Oh, that is something your embryologist will tell you, not me.
Yeah. Another, actually, this is also more technical question. I don't know, sir, whether we have to take it pre-incubation and post-incubation, which is the best TISA sample, and after TISA, in which plate TISA sample should be kept?
So incubation is a controversial thing. As you incubate the testicular sperm sample, the DNA damage slowly, gradually increases. However, when you incubate the sample, very often sperm which were immotile earlier become motile, and sperm which you could not identify may be picked up. Therefore, incubation is often useful in picking up sperm and knowing which are viable versus non-viable. So most centers will incubate at least for a couple of hours, and there are several papers favoring overnight incubation, showing that even if you didn't get sperm immediately, after overnight incubation, you may find sperm. So whereas some centers don't like the problem of too long an incubation. So when I do a TISA for Firuza, for example, she wants the TISA and the egg pickup to be timed very closely. Whereas with some of the other IVF centers, including at Lilavati, often we will do the TISA in the morning, the egg pickup in the afternoon, to give the lab enough time to go through the sample and incubate it. And if we do it with Naina Patel, Nanand, she often prefers it the previous day so that her lab can do a prolonged incubation and look for sperm. So the very fact that there are so many different approaches means that it may not matter. What media to keep it in? They put it in micro droplets of the sperm washing medium.
Okay. Sir, I have a question, little more practical one. Nowadays, probably the laptops and all people carrying their mobiles on their pant pockets are incremented in low sperm count. And how serious and how significant it is?
So laptops, nowadays I ask that question of everybody, and most people seem to be aware that they should not be keeping the laptop directly on the lap. So either they keep it on the table or they put some kind of support beneath the laptop. Also, the laptop gets uncomfortably hot. So anyway, if somebody is trying for fertility, we tell them don't keep the laptop on your lap even if there's a pillow, because we don't know about radiation. You keep it on a table. The mobile phone is trickier because people can't do without it. They have to carry it with them. The evidence is mixed. If you've exposed rats to high radio frequency, yes, the sperm count goes down. But how does that correlate with a real life situation where the phone is sometimes in the shirt pocket, sometimes on the table, sometimes in the pant pocket? We don't know. So practically what we tell patients is if you're trying for a pregnancy, at least during that period, better to keep it in the shirt pocket when you're out. And when you're at home, keep it on the table and not on yourself.
Okay. I think, sir, that covers at least the questions which have been there till now in the chat box.
Okay, so then I think it's been a nice long session. Sorry for the small glitches, but those are bound to be there. I think the webinars on Zoom have been excellent because they've allowed us to connect with speakers and audiences.
Hello.
Internet issues.
Again.
Yeah, I think,
Again,
sir, your net is gone, I think.
Some network issues there, yeah, from sir's side.
Hello, sir. Can you hear us?
Okay, I think I'm back.
Yeah, we can hear you.
Yeah.
Yes, sir. In between we lost you. We couldn't hear what you said last few this.
Oh, I think the net said it's time for lunch.
Yeah.
Right.
So I think
what I did say is thank you very much. It was a pleasure. Thank you for inviting me. And I hope these were practical points and should be of use to all of you. And stay safe and wish you a wonderful Sunday.
thank you so much, sir. It was really, I mean, the total take-home messages and very practical and crisp presentation. I think I'll hand over to Dr. Panandikar for concluding remarks, our Secretary General TOGS.
I have to thank him for all the questions.
Thank
He
you
had
so very
maximum
much.
queries, sir.
Yeah.
I think I was attentive for once.
Yes.
Thank you, Dr. Rupin, sir, for an exhaustive, very precise, and very educative lecture on oligoastenospermia and azoospermia. I've attended 2 of your lectures, conferences before, but I think there were too many distractions. So I couldn't really grasp the subject as I did today. But you have cleared so many of misconceptions, and you have given us many take-home messages. I'm sure delegates who attended must have a feast of a time. Thank you very much once again. Thank you, Swarupa, for moderating this session so well. Thanks to our President, Dr. Laul, and thanks to the entire Swissera team, Mr. Mukherjee, Mr. Patania, Brunal, Smita, all of you. You have done such a wonderful job. And I think if I've got a recording of this webinar, then you can share it with us with the password.
Yes.
Thank you one and all for attending.
Definitely, sir. We'll be doing it, sir. We'll be doing it, sir. And
thank you very much for
Thank you.
and,
Bye.
I think
Thank you, sir.
So
Let's wind up the webinar now.
yeah, all of you have a very wonderful day. Thank you so much, sir. And I think the rest of the Sunday you will be able to take some rest now.
Another
Thanks
webinar at 7 p.m.
Oh,
God.
okay, sir.
Bye.
thank you, Rajiv sir, Datta Panandikar sir, and Swarupa ma'am. And thank you, Rupin sir, for such a wonderful talk, sir. We have one of the choice available with us. Already, ma'am has already shared that the password which you were using is Clopid Max, which is with the clomiphene citrate. That's really a wonderful choice available in front of you, sir.
Yeah.
Thank you very much.
Okay.
Thank you very much.
Thank you all.
Sir, with your
Bye-bye.
permission, shall I end the meeting?
Yeah.
Yes,
Yeah,
yes,
Mrinali.
yes.
Okay, ma'am. Thank you. It was a great session, ma'am.
Thank you,
Thank
Mrinali.
you.
Thanks a lot.
Thank you, everybody.
Thank you, Batania, sir.
Thank you very much, ma'am.